As we know, the diagnosis of glaucoma is based on the triad of intraocular pressure management, the visual field defect, and the disc damage. The office measurement, I want to repeat that it is a single snapshot, so the status of 24 hours intraocular pressure we do not know. The visual field defect is a subjective test. Although it is not completely objective is the disc evaluation because it requires the subjective interpretation. However, it is far more objective and reproducible than the visual field estimation. Reminding Paul Chandler in 1960 says that the appearance of the disc may be the most important guide to the management of glaucoma. I just want to know how many of you think of this disc is not glaucomatous. Just raise your hand. Okay, those who are thinking that this disc is glaucomatous is probably due to the curve disc ratio of 0.7 with, if you consider the neuroretinal rim with the thinning of generalized thinning of neuroretinal rim. But if I give this picture of left eye, what about the asymmetry of curve disc ratio? In the left eye it's about 0.5 curve disc ratio, whereas in the right eye it's 0.7. Those who are still thinking that it is not glaucomatous, just I want to tell that you should also consider the disc size. Along with the asymmetry in the curve disc ratio, there is asymmetry of the disc size. So what are the points? Just the main points. Curve disc ratio is not the only deciding factor. You need to concentrate on the neuroretinal rim, both configuration and the width of the neuroretinal rim. You need to consider the disc size, and overall the decision making is on the whole scenario. What about the disc in this case, where you can think of those who are concentrating on neuroretinal rim configuration? You can see the lower is more than the upper, but you also need to consider the absolute width of neuroretinal rim. So this is a glaucomatous disc. This is a disc of a patient without any glaucoma, probably with a distinct peripapillary crescent, but this is probably due to the misalignment of choroid and retina. This papillary crescent has been formed, and you need to differentiate sometimes glaucomatous disc from the normal physiological variation like sloping cup. You need to also concentrate the color of the neuroretinal rim, especially in the left eye, where you can see the neuroretinal rim is pale, which helps you in differentiating from pseudoglaucomatous optic disc. The last but not the least is, if you consider the curve disc ratio in this case, probably if you go by the pallor, the curve disc ratio will be 0.5, whereas if you go by the contour of the cup, you can get that the curve disc ratio is 0.8. In the evaluation of glaucomatous disc damage, it is the contour curve that is most relevant, not the color cup, and which can be better appreciated by the stereoscopic fundus viewing. This is the normal teaching, how to evaluate and what are the points to evaluate, how to interpret whether the disc is abnormal, and if it is abnormal, whether it is glaucomatous or not, and how the disc evaluation helps in the management of glaucoma. You can evaluate the optic disc by direct ophthalmoscopy, indirect or slit lamp examination, but best is the slit lamp biomicroscopy with the help of either 78, 66 or 90 diopter lenses. The advantage of slit lamp biomicroscopy is to appreciate the contour cup as opposed to the color cup. The border between the optic cup and the neuroretinal rim is determined by the contour and not by the pallor. And usual temptation is to equate the central pallor of the disc with the cup. The points, size and shape of the optic disc, configuration and depth of the optic cup, the neuroretinal rim, the curve disc ratio, peripapillary region, the retinal blood vessels, and disc hemorrhage, and last but not the least is the nerve fiber layer. Usually disc less than 1.5 is considered to be small, where more than 2 is considered to be the large. The advantage of slit lamp biomicroscopy is you can directly evaluate the disc size, but consider the lenses used as well as the image magnification. The large discs have the large physiological cup as opposed to the small discs which have lower anatomical reserve. In this disc, symmetrical disc with a curve disc ratio of 0.5 in both eyes I have found a visual field defect in the upper arcuate area in the left eye. After looking carefully, I have seen that there is some evidences of nerve fiber defect in the lower region. Eyes with large discs are more prone to develop glaucomatous fiber loss, whether the discs are abnormally large in glaucomatous eyes with high myopia. Considering the shape, altered shape is usually due to the oblique entry of the optic nerve and which may be associated with the sloping cup. In case of the tilted disc, it is due to the abnormal oblique entry, and the tilted disc may show the abnormal visual field defect corroborating to the crescent. Normal shape of the optic cup is horizontally oval. Larger the optic cup, deeper it is, and the deepest optic cup is usually found in the juvenile open angle glaucoma and traumatic glaucoma. Deeper the optic cup, smaller the parapapillary optic atrophy. Considering the neuroretinal rim, you should concentrate configuration, size as well as the color of the neuroretinal rim. Regarding the configuration, Isent rule usually denotes that the width of the neuroretinal rim is maximum inferiorly, followed by superior, then nasally and temporally. The characteristic configuration is of utmost importance in diagnosis of early glaucomatous optic neuropathy, and in cases of early diagnosis, the temporal inferior and the temporal superior disc sector should be checked carefully. One of the main target of disc evaluation is the size of the neuroretinal rim. The neuroretinal rim thinning may be generalized or it may be localized in the form of a notch. When the neuroretinal rim is thin or suspicious to be thin, you should look for other evidences like the nerve fiber layer defect or any parapapillary atrophy corroborating to the area of neuroretinal rim thinning. In case of the color of the neuroretinal rim helps identifying non-glaucomatous discs. Pallor with cupping is very rare in glaucoma except in cases of some acute ACG where there is high rise of intraocular pressure for some interval of time. Regarding the cup disc ratio, vertically is more important in the glaucoma. Higher cup disc ratio can be physiological in large disc, whereas the average cup disc ratio can be pathological in small disc. In case of the disc size, you should always consider when there is asymmetry in the cup disc ratio. Parapapillary chorioretinal atrophy by itself does not have much diagnostic value and should be differentiated from the myopic crescent and, as I told, the inferior crescent in the tilted optic disc. Retinal blood vessels and disc hemorrhage, if there is generalized narrowing of the retinal blood vessels, it's characteristic of the optic nerve damage but not characteristic of glaucoma, but focal narrowing is more pronounced in eyes with normal tension glaucoma. Considering the disc hemorrhage, about 99% specific for glaucoma, but because of low sensitivity, not at all sufficient as a single variable to separate normal eye from eyes with early glaucoma. The disc hemorrhage, if it is associated with localized nerve fiber layer defect and the neuroretinal rim thinning, then it is definitely essential to diagnose glaucoma, and in established glaucoma sometimes the disc hemorrhage suggests progression. Last but not the least is the retinal nerve fiber layer. It is better appreciated with the red-free filter. As you can see here, retinal nerve fiber layer defect indicates thinning of nerve fiber layer if it is more than 50% loss of retinal nerve fiber layer thickness. Most visible in the temporal inferior sector, and the localized defect can be easily detected rather than generalized defect. Localized defects are defined as the wedge-shaped defect and running towards and touching the optic disc border have to be differentiated from the pseudo defects and search for the nerve fiber layer defect in suspected notch. The documentation of the disc finding is one of the most important part in the management of glaucoma. If you get a disc and cup like this, you will denote the cup disc ratio is about 0.7 with inferior notch. If a disc like this, the cup disc ratio is about 0.8 with thinning of inferior rim, or you can say it is a broad notch. The pallor is usually indicated by the hatched line. The disc like this indicates cup disc ratio of 0.6 with pale inferotemporal rim, whereas the cup disc ratio of 0.6 with generalized pallor is usually indicated by this. Now I need to interpret whether the disc is normal or abnormal, and if it is abnormal, whether it's glaucomatous or pseudoglaucomatous optic disc. Usually follow the rule of 6. curved disc ratio, if it is more than 0.6, considering the disc size and asymmetry. Neuroretinal rim size in anywhere if it is less than 0.2. Neuroretinal rim configuration if there is any departure of isn't rule, and the color of the neuroretinal rim, as well as if there is any nerve fiber layer defect and the disc hemorrhage. These are the rule of 6. Just exercise this rule of 6 in these patients. Probably this is a curved disc ratio of 0.7 with inferior notch, and you will be happy to get a visual field like superior arcuate, and probably the disc is glaucomatous and you can diagnose as glaucoma. In this case, if it is 0.7 with, you can see the inferior nerve fiber layer defect, and inferotemporal nerve fiber layer defect may indicate some scotoma in the superior arcuate area. This is 0.8 about bipolar thinning. You will be happy to get a biarcuate scotoma like this. In this case, it's 0.7 with superiorly no rim and there is a nerve fiber layer defect. You will be happy to get almost inferior hemifield defect. And a disc like this 0.9 with thinning all over, you may get the biarcuate scotoma or advanced glaucomatous field defect. Pseudoglaucomatous discs are misinterpreted as glaucomatous. Pseudoglaucomatous optic disc can be of some physiological variation, developmental anomaly, non-glaucomatous causes of acquired cup, non-glaucomatous causes of acquired pallor. Physiological anomalies should be differentiated from the glaucomatous disc like large cup, sloping cup, gray crescent, myopic disc and oblique entry. Glaucomatous disc should be also differentiated from developmental anomaly like megalopapilla, congenital tilted disc, optic disc pit, optic disc coloboma, morning glory syndrome, myelinated nerve fiber and peripapillary staphyloma. In cases of the non-glaucomatous acquired cup, the AION or optic nerve infarction may be misdiagnosed as glaucomatous. In case of non-glaucomatous acquired pallor, the dominant optic atrophy or hereditary optic atrophy, traumatic optic neuropathy and optic neuritis should be differentiated from the glaucomatous disc. The distinguishing features of glaucomatous disc from the pseudoglaucomatous disc, you should concentrate on the neuroretinal rim with maintenance of isn't rule or is helpful in differentiating the physiological variation. This is a non-glaucomatous disc as opposed to the glaucomatous disc in this case. You should concentrate on the color of the neuroretinal rim. Neuroretinal rim pallor is the most helpful differentiating sign for non-glaucomatous excavation. This is a non-glaucomatous disc as opposed to the glaucomatous disc whether the neuroretinal rim is pink. Pallor restricted to the cup is typical of glaucomatous optic atrophy, whereas pallor extend beyond the cup is a non-glaucomatous optic atrophy. This is a non-glaucomatous optic atrophy where the pallor extends beyond the cup, but this is a glaucomatous optic atrophy where the rim, whatever is remained there, is pink. Specific feature of the glaucomatous cup is the remaining rim should be pink. Now, how the disc evaluation helps in the management of glaucoma. Where the visual field will not guide or the patient may not be capable enough of doing the visual field, the likelihood increases when the disc finding correlates with the visual field defect. Eyes with the larger disc are more prone to have glaucomatous damage. The disc evaluation helps in setting the target intraocular pressure, and any new findings indicate progression in cases of long-term glaucoma management. Eyes with advanced glaucoma requires intraocular pressure below the average normal. The disc evaluation also helps in setting the target intraocular pressure. Eyes with limited cupping confined to one pole, the disc appears to withstand the pressure better. Still, in my 15 years of glaucoma practice, I feel the real truth is the appearance of the disc, which may be the most important guide to the management of glaucoma. And the confidence will increase if the disc evaluation or clinical evaluation is complemented by the objective or quantifying the features, and you can get this with the help of recent development of imaging. The recent focus is on the optic nerve head and the retinal nerve fiber layer, because the changes in the optic nerve head and the retinal nerve fiber layer may be detected before any detection in the visual field evaluation. Although the stereo disc photography remains the cornerstone in the glaucoma management, but the standardized objective method to evaluate or quantify the optic nerve head changes and the retinal nerve fiber layer is needed. Because of the need to diagnose glaucoma earlier and also in objective manner, there are the development of scanning laser polarimetry, SLP, confocal scanning laser ophthalmoscopy, and the optical coherence tomography. Considering all the limitations of each and every one, the optical coherence tomography has got the greatest potential for glaucoma diagnosis because it is the only technology which images the optic nerve head and directly determine the retinal nerve fiber layer thickness. Retinal nerve fiber layer is in theory more sensitive than the optic nerve head changes because it can be, in cases of the age-related retinal nerve fiber layer thinning, can be detected before the visual field defect, and the retinal nerve fiber layer thinning is directly correlated with the loss of ganglion cells, which is the primary event in glaucoma damage. If you get a disc in this, in case of the left eye, there is suspicious thinning of the neuroretinal rim in the inferotemporal aspect. And with the with the recent technology, if you quantify this defect or the nerve fiber layer thinning here, then that will be more beneficial for your diagnosis or progressing that patient or following up that patient. This is a standard retinal nerve fiber layer and optic disc report. At the top, there are the retinal nerve fiber layer thickness map. This is the color coded with the color legend. This thing beside it, and the cooler color indicates the thinning of the nerve fiber layer rather than the hotter colors. Below that, there are the 8 sectors with average retinal nerve fiber layer, and all these are color coded based on the normative database. Like if it is green, likely to be normal, which is probability value of less than 5% of the normal. If it is yellow, it is probably borderline, and if it is red, likely to be significant. Below that 8 sectors with average retinal nerve fiber layer, it has got also an absolute value as well as the color code. Below that is the examination date and the signal strength, which you should look for before assessing whether the nerve fiber layer is abnormal or not. Below that exam date and SSI, the summary parameters both for retinal nerve fiber layer as well as the optic nerve head, and if there is any abnormality, it is also color coded according to the normative database. The most important, and which we usually look into, the TSNIT graph. It usually denotes the nerve fiber layer thickness of temporal, then approaching to the superior, nasal, inferior, and back to temporal. This TSNIT graph indicates a black line which is overimposed on a color shade of like green, yellow, and the red. So we can find out whether the graph touching the abnormal area or it is within the normal range. The limitations of optical coherence tomography is probably to get a good signal strength, you need to dilate the pupil. The media opacities affect the results of the optical coherence tomography. The normative database is very small. There is no progression software, and only it is a sampling of points along a circle. So you need to judge judiciously, look at the signal strength before judging the RNFL analysis to be abnormal. Few points like myopes have low average nerve fiber layer thickness, so significant proportion of myopic eyes will be classified as outside normal limits when compared to the normative database, and abnormal in some cases of physiological variation and developmental anomalies, which is very important to differentiate the glaucomatous from the pseudoglaucomatous. The retinal nerve fiber layer and the optic nerve head analysis in OCT provides a sufficient corroborative disease evidence if judged judiciously with clinical correlation and as a complementary to disc evaluation. Thank you very much. I cannot finish this without acknowledging my teachers like GC and Dr. Mandal, and my colleague Dr. Dipanjan Pal, and my patients also. Thank you very much.